Dr. Ayyappan S. to chair the next session. Now I would like to welcome Dr. Wesley M. Jose, a distinguished medical oncologist from Amrita Hospital, Kochi. Over to Dr. Wesley to share his insight on neoadjuvant chemotherapy in colonic cancers.
Thank you so much, and this is for my 10-minute of fame. Most of the stuff that I would want to discuss has already been discussed, and most of the stuff that people have commented on is what is going to be seen on the slide. So probably this is just a bridging and putting it all together so that it makes some sort of sense. Neoadjuvant chemotherapy in colon cancers, even though we do understand that rectal cancer and all the other tumors that we talk about seem to have a very impulsive role of neoadjuvant chemotherapy, because most of the surgeons would agree that it's always best to send it across to the medical oncologist. But when it comes to colon cancer, the standard truth remains that upfront surgical resection with adjuvant chemotherapy for stage 3 and those for stage 2 disease with additional adverse factors still remains the gold standard, something that we all follow. And it's very unusual for any of us as medical oncologists to come across a patient who has been sent across to you because it's a T4 tumor and the surgeon doesn't want to operate. We just heard about multivisceral resections, and we have surgeons who are really good here, the few of them that I know. In that scenario, they don't hesitate from doing a surgery and sending across to medical oncologist. And the biggest fear, probably what they have, is if the disease does not respond to your chemotherapy, what do we do? An operable situation which could have been managed with a slightly difficult surgery, which we are willing to take, has been lost. That window of opportunity loss is something that probably, as a medical oncologist, I also jitter in my shoes, wondering if this progresses, what do I do? The neoadjuvant paradigm is quite a common event. So it is not something that we have not heard of, not something that we have done, but in scenarios of esophageal cancer, G-junction, gastric carcinoma, rectal, pancreatic, I think something that we all offer to every single patient of ours, and we do get a reasonable result, even though we might have our own understandings of how these studies were done and what were the comparator arms and whether they were the best arms or not. Those all aside, even though the medical oncologist might have his own doubts about the benefit of neoadjuvant in each of these settings, the surgical oncologist somehow seems to be very convinced that in all these scenarios, a neoadjuvant chemotherapy should be done. But when it comes to colon, the same thing doesn't matter. The stated logic for neoadjuvant chemotherapy is simply that it will aim to shrink the primary tumor, allows the downgrading, removes the metastatic microscopic disease, and probably get R0 resection. But truthfully, the truth of the matter remains that whenever we talk about any of these malignancies, you're talking about a systemic disease. We're not talking about a local disease. And the second thing that's most important is probably the biology of the tumor matters in what ultimately happens to each of our patients. And it is not something that you have done technically by doing excellent surgery or me by giving in all the poisons in the world to make sure this man lives or not. Just to put that thing in perspective, this is a Dutch study which looked at what we heard today morning, Natera and Signetra, looking at ctDNA. Right in the beginning, when you have, this is a patient, this is the ctDNA of the tumor volume, and on that hand is a CA19-9. This is a large group study. And you realize that by the time the tumor is about 10 to 50 ml, you see quite a large number of patients who have detectable ctDNA, even though the disease is not symptomatic, even though the patient is not symptomatic, the disease is not causing trouble, you already have ctDNA in the circulation. So you're not dealing with a localized disease. So definitely what matters to the patient over a period of time would be the overall survival benefit that you and me want to give to these patients. It's not the best of the surgery or the best of the chemotherapy or the least toxic chemotherapy. What you're trying to do is give an overall survival. Now, this was the rectal cancer paradigm, multiple trials done, all of them proven that it helps. And those were real beautiful numbers. You have the pathological CR rate, which almost doubles up when you're using neoadjuvant chemotherapy. The distant metastatic rate is reduced. if rectum is the other end of the colon, then why is it that rectum alone should have the benefit and colon doesn't? We do realize that the maximum effort the surgeons have probably put in because of the challenges involved was in the rectal cancer area. So your surgical techniques became super good, not that people are not doing enough in the colon area, but the rectal area seemed to be having a lot more focus and a lot more work. But even in colonic cancers, you have a large number of R1 resections, and most of us medical oncologists would come across those kind of situations where nodes are not completely taken or the margins are positive. It also depends on when the surgery is done. Now, the neoadjuvant concept did not start recently, even though it seems to haven't got any traction. We all believe that neoadjuvant is still not there, not yet reached their point, but the studies have started about 15 years ago. The initial one was some of these retrospective studies that was done. This was a Spanish trial, that was an NCDB trial, large number of patients. And in all these patients, they have realized that a small group of people were there who were given neoadjuvant chemotherapy. And those patients did seem to have some benefit, but it never accrued to the kind of benefit that you come across in other scenarios. Dr. Senthil was talking about breast cancer and colon cancer, a comparison. Now, breast cancer, when you see a pathological CR, everybody is very excited. But rarely you come across situations where in colon cancer or in esophageal malignancies, despite your neoadjuvant chemotherapy, you get a PCR. You do get an occasional time, but it's not something. Now here in the first one, you had barely a 4.5% PCR. On the other hand, there you had a survival, you had a reduction in the size of the tumor, but there was no survival benefit. And from there, we realized that T4B was probably the only subgroup of patients who seemed to have some sort of benefit. The rest of them did not. And these are a huge number of trials. Dr. Senthil was talking about 4 trials, but I think they have a whole lot more of them which are running, some of them in smaller numbers, but they are all there. We don't have answers to this question. There are 3 trials I would like to focus on. This is the first one. This is the Prodigy 22 trial. The experimental arm had Folfox, 4 cycles to be given, pre-chemo, followed by 3 weeks later a surgery, and then 8 cycles of Folfox. The control arm was the conventional, go ahead with surgery upfront and follow it up with Folfox 12 cycles, if in case there were reasons to give the same. There was a third arm in this, which also included KRAS wild-type patients who were given the anti-EGFR drugs. But the anti-EGFR drug was pulled back because it did not seem to have benefit. It was a futility trial. Now, the Prodigy 22, what it showed was simply this, that the compliance rate pre-op was very good. You had 95% patients who finished the chemotherapy neoadjuvant component and the adjuvant courses. Only 73% of them started the adjuvant arm. The tumor regression grade was 44% versus 8% in the control. A trend towards downstaging was seen. No differences in R0 resection. So that is where my surgeon is going to contend, saying, what's the big deal that you have done? There is no difference in the R0 resection that I would have done upfront. But you made a mess for me, because at the end of it, after chemotherapy, definitely there are difficulties that you're going to face as a surgeon. Healing issues, waiting time, liver concerns because of the chemotherapy that you've given. Survival didn't change. Disease-free survival didn't change. The major hitch with this particular trial was that in the control arm itself, there were 33% of patients who were found to have low-risk disease who barely needed chemotherapy. So you ended up giving neoadjuvant chemotherapy based on pure radiological facts, which may or may not have been appropriate and correct. You're going to have a talk after this on radiology, which is done by somebody who has been a part of the Foxtrot trial, which I'll be talking about. And this particular dependence on purely radiology to assess where you're going probably might be a false start. The second trial is the NeoCol trial. Here, the experimental arm had Kipox, either 3 cycles, or Folfox 4 cycles, followed by surgery, followed by the same regimen as an adjuvant, or you had a control arm again with an adjuvant treatment. The concerns here, 73% were classified as T3, with a median outgrowth of 11 millimeter, while 26% were T4. The median chemotherapy was same. There were more postoperative complications in the standard group. The postoperative patients in the standard group had about 88 of them had no indication for adjuvant chemotherapy. DFS and OS did not change. This is probably the mother of all the trials that we're going to talk about. The previous two trials did not seem to have any advantage in terms of neoadjuvant chemotherapy. This was Foxtrot trial. This was not powered to detect the differences in overall recurrence, cancer-specific survival, and overall survival. This again had three arms like that, like the initial trial. You had FOLFOX for 6 weeks, followed by surgery, followed by FOLFOX for 18 weeks. You had the second arm, which was KRAS wild type. We were given panitumumab. That arm was again shut off. You had the third arm, which was straightforward control arm, which was surgery, followed by FOLFOX as required. Now, if you look at the tumor regression grade by treatment allocation in the neoadjuvant group and recurrence after surgery by regression grade, you look at the complete responders and patients who had no response. You have a reasonable big number of patients, 35 of them, who doesn't seem to have a response. So mild regression to no regression is not very different if you look at the patients who have received the chemotherapy. If you would have not received the chemotherapy, probably you would be lying in the last corner. But look at the graphs down here. They don't seem to look very different from each other. Right? The outcomes of doing the surgery after the cycles of chemotherapy, definitely there is a tumor regression. Pathologically, in numbers, there is a regression. But does that translate into a better surgery? Does that translate into better outcomes for the patient? Is not sure in this situation. So Foxtrot also had the confusion of not really initially integrating the concept of IDEA, because here, when it comes to chemotherapy in colonic malignancies, the idea is to bring down the number of cycles. You heard a little while ago that not all patients who have colonic malignancies need an intense 6 months of FOLFOX or a CAPOX regimen. So you have a scenario where you could probably get away with 3 months. But what do you do when you have given the initial chemotherapy? How do you decide? Because you really don't know what the initial scenario was. That's not an optimal staging that you have got right in beginning. You have had a surgery and then you got optimal stage, you decide 3 months versus 6 months, because then you can classify as low risk, high risk. Whereas if you're doing this as neoadjuvant chemotherapy, it's always difficult to figure out what do you do next. Do you call them high risk or do you call them low risk? Do you call them low risk because it has been downstaged? Would you stop off the treatment in the adjuvant setting? It always creates a confusion because you're purely depending on the radiological factors. Now, staging preoperatively with a CT scan is currently associated with close to 30% of patients being over-treated, which is definitely not the interest that any of us have. And probably there was no reliance on biomarkers, so it was difficult. But something that we learned from this study, which was extremely important, was the benefit or the impact of the MMR status. And we realized that patients who were deficient MMR were the ones who had no response to chemotherapy, and those who were proficient MMR were the ones who had the benefit. And this differential effect in the MMR probably has much more meaning than what we are trying to prove in terms of neoadjuvant chemotherapy. So the major hindrances to neoadjuvant chemotherapy in the locally advanced colon cancer, radiographic staging is a concern, which probably Dr. Gina will allude to when she speaks. The sensitivity and specificity for identifying T3, T4 versus T1 and T2 is beyond the muscularis propria is 95% and 50%. This is as per the Foxtrot. The NCDB evaluated a lakh patients, and they said the T stage was 80% and 83 was the end stage sensitivity for these patients. The agreement increases when the size of tumor increases, but agreement decreases when the size of tumor decreases. And what really happens to the non-responder tumors? The NCCN has already agreed upon T4B as the standard criteria for using FOLFOX. We all depend on biomarkers, and obviously it was something that was going to come into this picture too. The biomarker-driven cancer studies in colon in neoadjuvant setting are two of these, niche 2 and niche 3. Niche 2 used nivolumab and ipilimumab in locally advanced, and niche 3 used nivolumab with relatlimab, which is an anti-LAG. Niche 2 used a simple concept of in DMMR patients using Nivo 2 doses and 1 dose of IP followed by surgery. Somebody was talking about having got a patient who got immunotherapy and it seemed to flare but found no disease later. This is the best waterfall plot you can ever have, everything falling down, because there's an occasional time when you see everything is downwards. It doesn't seem to show any upward graph. Niche 3 was the similar story, and you found that almost 90% of the patients had a complete PCR. So probably the idea of neoadjuvant chemotherapy should go in the direction of biomarker-driven than radiology-driven ideas of giving treatment. Neoadjuvant is not for everyone. With superb surgeons here, probably they can do resections still. You can still plan on adjuvant, which is more appropriate. So I'm not here to say neoadjuvant is not good, but there are very niche areas where you could probably use neoadjuvant, where you think loss of function, a big organ damage, or a patient who was unlikely to respond to chemotherapy is going to be involved in this. And if you're going to look at radiology, you're going to listen from the expert after this. In the real world, the radiology reports, 2 of them don't ever match, even if it's in your own institute. And my own experience, we had run a clinical trial on PERSIST and PET in myeloma patients, and we had a husband and wife couple who were the nuclear medicine specialists, and they couldn't agree on the same thing. So I'm not sure whether it was because it was husband and wife or it was because 2 radiologists didn't agree. But even if there it didn't agree, I'm very unsure whether we can use this whole concept of neoadjuvant chemotherapy across the board for all our patients. With that, I'll stop. Thank you. That's probably true.